For exam dates, previous batch students, for exam dates, you can check the WhatsApp status. Wait till 23rd of Feb for the links to arrive. This is for previous batch students who are still attending the classes. Those who are joining late, please help them out with the page numbers. It's page number 550, 155, severe acute malnutrition. So coming to the topic, severe acute malnutrition or severe wasting, okay? There are different types of malnutrition, protein energy, severe acute, okay? So here, how to identify if a child has severe acute malnutrition or not? It's usually when a child has very low birth weight or even while growing up, okay, the child's weight is very low as compared to its height. Okay, there is a normal growth chart which more or less a child's weight gain and height, okay, should be in a healthy range. Okay. Am I audible to all? Is my voice clear? Okay. So it is defined by very low weight, okay, for height, visible severe wasting, or presence of any nutritional edema. This could also lead to severe acute malnutrition. Okay, there are two types of malnutrition. The child's development in womb is, it comes with different factors. Okay, that we will discuss in nutritional requirements for lactating mothers and pregnant mothers. Okay, in that chapter we will discuss these topics. So mid upper arm circumference. Okay, at a community health level, this is what you can check to just to identify in what range your child is, okay, or any child is. Is a child going through any malnourishment? Okay, so for mid upper arm circumference, first you have to find out the length of the upper arm from the tip of the shoulder, okay, till the elbow. What is the length? Divide it by 2, okay, you will get the exact centimeter at which you have to find the circumference. Okay, first you have to find the length of the upper arm, okay, from shoulder till the elbow, okay, divided by 2, whatever is the length, okay, at that length you have to place the measuring tape to find the circumference. Okay, if the circumference, if the mid upper arm circumference is, if it is less than 11.5 centimeter, okay, it means the child has malnourishment. Okay, if it is more than 11.5 centimeters, child is comparatively healthy. Okay, but if it is less than 11 or 11.5 centimeter, it means the child is malnourished. Okay, and in which age group you can do this? From 6 months to 59 months. Okay, so kids who come under this age, approximately 5-year-old, okay, 6 months to 5-year-old, to a 5-year-old child, approximately 5-year-old child, you can check the upper arm circumference, mid upper arm circumference, to find out is the child malnourished or not. Okay. Height, there are different statistics for finding this out as well, that we discuss in detail for those students who have joined for pediatric health nutrition, child health nutrition. Okay, in those subjects in detail we are discussing about the different anthropometric measurements and all, which will classify which kind of malnourishment a child is having. But is it clear to all so far what is mid upper arm circumference, how to check it, and what should be the inference? Is it clear to all? So coming to the classification of severe acute malnourishment, okay, marasmus, kwashiorkor, and marasmic kwashiorkor, that is based on clinical classification, okay, clinical features, okay. But the severity of it and the complications of it, based on the severity and complications, that is another classification for severe acute malnourishment. First is severe wasting, that is marasmus, okay. You can see here. Am I audible? Is my screen visible? Am I audible? Is my screen visible? Is my screen visible? Am I audible? Is my voice breaking now? So severe wasting. Here on figure B, you can see it's a child who has severe muscle wasting. Okay, you can see the bones are very prominent. Okay, very thin skin, wrinkled skin, and the bones are very prominent. You can count each and every one of the ribs the child has. Okay. Nutritional edema, figure A, you can see here. The child is thin, but if you see the abdominal part of the child, it is edematous. Okay, it is protruded. Abdomen is protruded. Distended abdomen that has edema. Okay, that is swelling, swollen ankles, swollen lower limbs, scaly skin, flaky skin. Okay, that is nutritional edema. We call it as kwashiorkor. Okay, this is the clinical classification based on the features, clinical features. Okay. Based on the complications, medical complications, you have uncomplicated severe acute malnutrition and complicated severe acute malnutrition. In uncomplicated, children who are clinically well, they don't have any signs of infection or any indication of hospital admission. Okay, the appetite is also fine. And these patients are like, they can be treated as an outpatient basis. They can come visit the hospital, get their nutritional supplements, go back home and follow up with whatever guidelines the doctor has given. They don't require to be admitted within the hospital. But in complicated severe acute malnutrition, the child's life could be threatened by conditions like hypoglycemia, okay, hypothermia, okay, blood sugar levels are too, glucose levels are too low, body temperature is too low, okay, that could be fatal as well. Okay, so in this complicated kind of malnourishment, you will require a hospitalized care. The child has to be admitted on an inpatient basis. It will take weeks for the child to recover, okay, and even after recovery, follow up care, okay, after discharging the child, follow up care is given. Okay, so this is the classification of severe acute malnourishment. Is it clear to all? Height and weight ratio will keep on changing. Okay. Reason being, India's nutritional status is changing. Okay. We were once a population which was completely malnourished. Majority of the population was completely malnourished. Okay. But as decades passed by, the nourishment, the nutrition in Indian population has improved, and now it has surpassed improvement as well. Now we are looking at cases of obesity, childhood diabetes, young diabetes. Okay, so the health statistics in Indian population is changing. Based on this change, based on this dynamic, the height to weight ratio of kids will also change. Okay, with the improvement of nutrition is what happened, is that girls are attaining early puberty. That is one of the reason. Okay, now the nutrition for girl children have improved a lot, so they are getting early maturation, early puberty, right? So these ratios will keep on changing. The ratios given by the government, when you find it in textbook, any fact given by the National Institute of Nutrition, okay, ICMR, okay, Indian Council of Medical Research, whatever facts they are giving, you have to reconfirm it with the website, with their website. Okay. Is it clear to all? Regarding any ICMR data, NIN data, okay, any facts, Indian reference, male, female, that has also changed. So definitely the child's ratio will also change. Okay. We are a dynamic society. Our health is keep on changing. The average height, average weight, life expectancy, these all rates have improved a lot. Okay. So with that, check the websites, not the textbook. In uncomplicated, the child does not have severe life-threatening conditions yet. Okay, so they don't require a hospitalized care. As an outpatient OPD treatment, uncomplicated severe acute malnutrition can be treated. Okay. So coming to the clinical features, you can refer textbook also for this, almost it's the same. Okay, marasmus. It's usually seen in younger children, okay, less than 1 year old. Majority of marasmus cases are seen in young children. Kwashiorkor cases are seen in children who are a bit older than 3 year olds, okay, 3 or 4 year olds, okay. But marasmus is usually seen in young children, okay, infants less than 1 year old. Due to low calorie intake, and due to severe growth retardation, severe weight reduction in the body. Abdomen, you can see in the image, abdomen is completely shrunken, okay? The stomach has gone inside. The rib cages, the bones are very much prominent. There is no subcutaneous fat that this child has. The child has lost a lot of fat from the body, no subcutaneous fat at all. Prominent lips. Voracious feeder means the child has a big appetite. Okay, the child is really hungry, eats a lot. Okay, but it does not keep up with the health. Okay, because if the child has reached a stage of marasmus, if the child has reached the stage of marasmus, what happens is that intestines have stopped working properly. Okay, nutritional absorption and intestines have stopped working properly. Okay, so what happens here is that even if the child is a voracious feeder, eats a lot, it is not getting absorbed properly. The child will not have fatty liver here. Edema is not present. Okay, there is no swelling. You will see there is absolutely no sign of swelling. The child has an old man-like face. Okay. No hair changes is noted here. Dry, wrinkled skin is seen. The child is alert, but it is irritable. Okay. Requires adequate amount of protein, fat, and carbohydrates because uh, not just fat has been lost, muscle wasting is also there. So protein was also lost. Okay. And definitely carbohydrate requirements, energy requirements are not up to the mark. So the child will require protein, fat, and carbohydrate focused diet. Okay. So this is the clinical features of marasmus. Coming to kwashiorkor. So kwashiorkor, the name meaning of it is a disease that an elder child gets. Okay. So definitely a child who is older than 1 year of age, okay, 1 to 6 year of age, between that age group, if the child is malnourished, usually they will get kwashiorkor. Okay. And this is due to low protein intake. Mild growth retardation will be there, not severe, but in marasmus, you will see severe growth retardation. Okay. Mild reduction in body weight, but swelling is there, protruding abdomen because of swelling, ascites. Subcutaneous fat is reserved. The child does not lose the fat. Okay. Ribs are not prominent because swelling may overlap it. Okay. Poor appetite. In marasmus, the child is very hungry. In kwashiorkor, the child does not have hunger. Okay. Enlarged fatty liver. Okay. Fatty liver is absent in marasmus. Edema is present. Moon phases, it's usually because of edema. Okay, because it is because of swelling. The child has moon kind of a face, round, well-rounded face. Sparse hair, flaky paint-like skin. The child is very lethargic, no energy at all, and it requires adequate amount of protein. Okay, you don't have to focus more on carbohydrates and fat. Fat you still have to reduce a bit because the child is suffering from fatty liver. Okay, but you have to focus more on a protein-based diet in kwashiorkor. So is the difference clear between kwashiorkor and marasmus? Is it clear to all? Then we have another condition called as marasmic kwashiorkor. From the name itself, we can understand the child would be having features of both marasmus and kwashiorkor. Okay, and it usually takes place in a child who is between the age of 2 and 4. Okay, usually it takes place in a child who is in a age group. Yeah, mental health issues will be there. When there is a severe growth retardation, it will affect their brain development as well. Okay, severe growth retardation will definitely affect brain development as well. So you have marasmic kwashiorkor, a severely malnourished child with features of both marasmus and kwashiorkor is seen here. The features of kwashiorkor are severe. Okay, edema of the feet, legs, and also hands are seen. Lower arms, edema in abdomen. Okay, face, but also there is a pale skin, hair. Okay, the child is unhappy. Okay, means the emotional health of the child deteriorates here. There are also signs of marasmus, wasting. You can see the upper arms and upper limbs. Okay, if you see the limbs, upper and lower limbs, the shoulder to elbow and from here groin to knees. Okay, it is very thin. The lower part of the extremities, both upper and lower extremities, the lower part of extremities have this swelling, kwashiorkor kind of feature, but the half of the extremities has marasmic kind of features. Okay, even though the abdomen has swelling, you can still see the ribs. So that is seeing the ribs prominence, bone prominence in the of the ribs, that is a sign of marasmus. Seeing the protruding abdomen, that is a sign of kwashiorkor. Okay, so this is the condition called marasmic kwashiorkor. You will see the mix of clinical features from both the disease condition. Is it clear to all? Then you have stunting, dwarfing, and underweight child. So this is a normal child in the center. Okay. Compare a normal child with a stunted child and a wasted child. Okay. Remember, these three children are of the same age. Okay. These three children are of the same age, but you can see the difference in their development. Okay. The child who has stunting, okay, their weight is not that much of an issue, but you can see the height. Okay. They are not able to catch up with a normal growth in their height. Okay, that is stunting. That is what we call as nutritional stunting. Okay, because of prolonged insufficiency of food, protein, energy. Okay, growth retardation will take place. Superficially, if you see this child on the left, it looks like a normal child. Okay, but if you compare the child with another child of the same age group, then that is where you will see the difference. Okay, superficially, a stunted child looks like a normal child until and unless their age is revealed. Okay, in wasting, you can see the child does not have that much issues with height. Height is approximately normal, okay? But severe wasting, all the bony prominences of a child's skeletal system, that is very much evident. Okay, all the bones, it is the child has lost a lot of protein. Muscle protein has been lost from the child. Lot of muscle protein is lost. Okay. Even the subcutaneous fat in this baby, that is also lost, okay, on the right side. This is a wasted case. So these were different types of childhood malnutrition. You have a normal child, okay, with a normal height and weight. A child who has wasting, height is approximately normal, but body is severely thin. Okay, no subcutaneous fat, no muscles. Okay, stunted child looks superficially normal, but when you compare it to their peers, they look very like dwarf like. They are very short in height, low height for age. Underweight child, okay, height does not impact much, but the weight is on a lower end based on their age. So far, is it clear to all? So changes in organs and system and in general health, what happens when a child is undergoing malnourishment? So digestive organs, pancreas, intestine, they undergo atrophy. Atrophy means what? People who are from the medical background, what do you mean by atrophy? Atrophy means decrease in size and number. Decrease in size and number. Okay. That is atrophy. Okay. So the cell size as well as the number of cells present, it will reduce. So imagine what's happening to the pancreas and intestine. They are getting smaller and smaller in size. Okay. When your cells are lost and the cell size is getting smaller and smaller, definitely it will affect the entire organ. Your entire organ will shrink, right? That is atrophy. Okay. So pancreas, intestine, okay, these all undergo atrophy. And when the organ has reduced in size, will the functions will also reduce? Will it affect the functions? It will. Okay. So how much of our enzymes they are supposed to produce? Okay. Whatever is the activity of the organs, that will also reduce. Okay. Reduced functionality is seen during malnourishment. But when you start the treatment, usually it will reverse its effect. Okay. It can come back to normal. With treatment, the size of the organ, the function of the organ can also come back to normal. Then liver, in case of kwashiorkor, okay, in liver, small droplets of fat will start to accumulate and it will lead to fatty liver. Okay. These small droplets of fat will increase in size. It will spread as well. Okay. From the sides of the liver, it will reach the center of the liver. Okay. And that's when you get liver failure, fatty liver in kwashiorkor children. And also bilirubin levels, okay, that will be affected. Clotting factors, that will be affected. Why is it? Why do you think? Any idea why fat is getting stuck to liver? Droplets of fat. Why is this happening? Any guess? Any wild guess? Why during malnourishment fat droplets accumulate in liver? No, digestion means breakdown. The fat molecules have been broken down. That's the only reason why fat molecules was digested. That's why it was absorbed. Okay. If the fat molecules was not digested, there was no chance it would have been absorbed. Okay. Intestine had already absorbed the fat molecules. It was digested, it was absorbed. But why it is accumulating in the liver? Any guesses? This is malnourishment, okay? The child is undergoing malnourishment. It's because there is not enough protein in the diet. Okay. To make sure the fat molecules are transported within the blood circulation and it reaches places where it is supposed to go and function. Okay. In absence of protein, there is no lipoprotein that can be formed. And since there is no lipoprotein formed, okay, what will the fats do? Whatever fats that have been absorbed, they will get accumulated in the liver because they don't have anywhere else to go. There is no direction in which they can go and do their work because there is an absence of lipoproteins, because this is a protein energy malnourishment. Okay, because of the absence of protein, there is no enough protein. Lipoproteins are not formed in the body, and when lipoproteins are not formed, there is nothing that can make the fats travel from one point to another. Okay, so they get accumulated. So they get accumulated in the liver. Okay, is it clear to all? That's how a malnourished child will get fatty liver. Not because the child has a lot to eat, it's because internally the child does not have enough protein which can handle the fat. Okay. Then cardiovascular system, that will also, heart will also undergo atrophy, means heart will become smaller in size. So definitely the cardiac output will be also less. Okay. When the heart's size is reducing, heart has become smaller in size, the cardiac output will also be less. The small heart can't pump large amount of blood. Okay. So when the heart is not able to pump enough amount of blood, what will happen? The extremities, specifically hands, palms, feet, okay, enough oxygen will not reach there. When the heart is not able to pump enough blood, the body will not, body parts, certain body parts, peripheral areas of your body will not be getting enough amount of oxygen. So that part of the body will look purplish, bluish, purplish, cyanosed. Cyanose means what? Bluish, purplish, purple discoloration, because there is not enough oxygen in that area. Okay. You hold your hands and fingers tightly for few seconds and you see the change of the color of the tip of your hands and everything. Okay. When you see that change in the color, when the fingertips appear purple bluish, it means that area is undergoing cyanosis. Okay. In adults, when this happened, you get cardiovascular diseases. You will get fatty liver as well, but you also get cardiovascular diseases. Is it clear to all? Next to the kidneys, GFR rate, the filtration rate of the kidneys will fall down. Okay, there will be dehydration, reduced. There is not enough blood that is pumped into the body. So there is less amount of blood that will be filtered. When the filtration rate falls down, there is not enough urine that is being produced. Okay, so that is how kidneys are affected. Kidneys GFR rate, filtration rate will fall down because there is not enough blood that can undergo filtration. Immunological system, immunity, that's very clear. The immunity falls. Okay, the child is prone to a lot of infections, recurrent infections and diseases. T cells will reduce, lymphocyte level will reduce. These T cells and lymphocyte levels are the ones that defend your body. Okay? They are the defense system on your body. Then you have mental development. Glial cells in your brain, okay, that reduces. So the brain development is affected. Vision is impaired. Okay, retinal development is affected. DNA, RNA, protein, okay, synthesis of DNA, synthesis of RNA will come down. Then hormones, those who have the textbook, table 8.2, page number 160. If you have a different page number, you can mention the page number in the chat box. So what all hormonal changes will take place is given in that table. Just go through it. Okay. Arrows have been given, which instigates is that hormone increasing or decreasing. Upper arrows means it is increasing. Lower arrows, okay, downward pointing arrows means it is decreasing. Okay. Page number 165, okay, new textbook. So next we have the biochemical and metabolic changes. One second, just give me 1 minute. So biochemical and metabolic changes. First is your protein metabolism. Protein concentration is becoming low and low because the amount the RD of protein is not being met. So amino acid level in your in the child's blood and the branched chain amino acids, these all essential amino acids, okay, they come down. Essential amino acids, there you require them through your food, okay, you can't synthesize that in your body. Non-essential amino acids, but the opposite takes place in non-essential amino acids. Okay, non-essential amino acids in your body, they can be higher or they can be normal, but essential amino acid concentration in your body, that will fall. Even the plasma albumin level, protein that is present in your blood plasma, that will fall down. Your immunoglobulins, okay, protein is required for making immunoglobulins, antibodies, okay. You will not have enough antibodies produced in your body, so more and more infections, the child will get more and more infections. Next, the lipid metabolism. Fatty liver is very common because too much of fat, that is droplets that are getting accumulated in the liver tissue. There is no enough lipoprotein that can make sure that these accumulated fat cells or liver tissue that can be moved out and get it into the blood circulation and let it go somewhere else and work. Okay, since you do not have enough lipoproteins, that can be done. So fat cells will accumulate in the liver over time again and again, and it will lead to fatty liver in malnourished child. Next, you have carbohydrate metabolism. So in cases of kwashiorkor and all, glucose levels are normal usually. In marasmus, usually the glucose level falls down. But the glucose tolerance level could be impaired. Even if you have slight, small amounts of glucose, the insulin levels and the blood glucose levels will go so high. Okay, at very small dose of glucose or carbohydrate, it can give you high blood sugar levels. Okay, that is the glucose tolerance that get affected. Electrolyted water, there are chances of deficiency of potassium or other electrolyte because of recurrent diarrhea. Okay, diarrhea could happen because of infection. Then vitamin A status, it's very important that it has to be corrected. As soon as you bring a malnourished child to hospital, the first thing they will do is give the child dosage of vitamin A. Okay, because we don't want blindness in a child because of a nutritional deficiency. Okay, the child went blind just because the child could not have access to vitamin A. That is a nutritional deficiency. So we try to prevent that. Okay, so the first thing that doctors and nurses will take care when they when they receive a malnourished child is complete the dose of vitamin A. There is no vitamin A prophylaxis. We will discuss that later. Okay. 1 lakh international unit or 2 lakh international unit of vitamin A doses are given to children based on their age. Okay, we will discuss that later. So to prevent night blindness and other infections, and to make sure proper cell differentiations is taking place in the body, vitamin A status has to be corrected. Coming to the treatment of protein allergy malnourishment, first is the nutritional requirement. Okay, dietary management has to be done even in hospital if the child is admitted. A big part of the treatment is dietary management. Okay, and later, even at home, dietary management has to be secured. Okay, for life-threatening conditions, ICU care, intensive care is given. Okay, but apart from that, once the child is out of ICU in general wards and all, the child will be given nutritional treatment. We will discuss that. Okay. And this nutritional treatment is not just to meet the immediate demand of the child, but also to make sure that the child is catching up with other healthy children. Because you have seen the child who is stunted, dwarfed, okay, the child who has undergone muscle wasting in comparison to a normal child. So this child has to do a lot of catch up. Okay, so nutritional requirement should also meet the requirements of catching up. Okay, foods that are rich in protein and energy is focused on. Okay, so for energy, am I audible now? So when it comes to the energy requirement, okay, the child has to be given 150 to 200 kilocalories per kg body weight of energy on a daily basis. So you have to weigh the child and see what is the weight of the child. And then based on that weight, existing weight, okay, 150 to 200 kilocalories per day, multiply that by the weight of the child. And that is the total calorie that the child should eat within an entire day. Okay. For children who are less than 2 years of age, toddlers, 200 kilocalories per kg body weight is given. But the children who is older than 2 years of age, 150 kilocalories per kg body weight is given. Cereal malt can be given, okay, because it has high calorie and it is good in protein as well. 50% of the total calories can come from carbohydrates. The remaining can come from fat and protein. When it comes to the protein requirement, so whatever is the existing weight of the child, okay, 5 gram of protein, 5 gram of protein per kg body weight on a daily basis should be given. So the protein intake has to be really high, okay. And the calories that protein should be providing should be around 10%. Okay, 50% can come from carbohydrates. 10% of the calories should come from protein. If animal source is the main source of protein, if the child is having plant-based or cereal pulse-based diet, then Up to 15% of the calories can come from protein-based diet. But if the child is having non-vegetarian food, 10% of the calories can come from animal-based diet. Milk protein is a much better option to reverse any manifestations of kwashiorkor. Okay. Vegetable proteins are available, they are good, but it's better to opt for milk protein to give a better result, to even to reverse the symptoms caused by kwashiorkor. Yeah, protein is 5 gram per kg. High protein diet. For a sedentary adult, it is just 0.8 gram. But a child who has kwashiorkor or marasmus, okay, severe acute malnutrition, their protein intake has to be around 5 gram per kg. Because the child has to do a lot of catch up as well, okay, not just to meet the requirements, but a growth catch up also has to be done. So these two purposes has to be fulfilled, okay. Yeah, fat percent, the calories from the fat, children can still tolerate it. Okay, children will not get any cardiac issues because of high fat. Okay, children can very well tolerate a good amount of fat in their diet. Okay, but saturated fat like buttermilk, milk, coconut oil, they are preferred, because unsaturated, if you're giving unsaturated fat like vegetables, oils or seed oil, that could lead to diarrhea, or if the child already has diarrhea, it can worsen it. Okay, so it's better to give saturated fat to the children than unsaturated fats. Ghee, okay, ghee, butter, it all comes under saturated fat. Electrolytes and vitamins. Vitamin A deficiency is the serious concern. Immediately when the child is hospitalized, vitamin A prophylaxis will be given. For electrolytes, ORS can be given, or the child can be put on IV therapy, intravenous fluids. Okay, so that will take care of the electrolytes. Unsaturated fatty acids are good, but they can trigger diarrhea. And diarrhea can really be fatal in children who are less than 2 years of age. Okay, so you have to go by the priority. You have to prioritize what kind of treatment you have to give here. So management of these cases, this is for students who are from a medical background, okay? Those who are not from a medical background, this management part, you should know it, okay? But you are not supposed to practice it. Okay, so doctors and nurses here, they can practice it because they have the field to do it. Okay, so other students, you just please pay attention, just understand the strategy that we follow here in management. Okay, so we have 3 stages of management: initial, rehabilitation, and follow-up. Okay, so initial treatment means whatever happens in the ICU, because you have received a complicated severe acute malnourished child. Complicated. Okay, it's not uncomplicated, it's complicated. So the first few days, the child will be in ICU. Okay, all life-threatening problems will be taken care here. Okay, like hypoglycemia, blood glucose levels are so low, it's fatally low. Okay, hypothermia, the body temperature of the child is fatally low. Okay, dehydration. So these conditions are fatal. Any infections, okay, any severe infections, multiple infections, sepsis, cases of sepsis can also happen. Okay, so these things you have to take care in a critical care unit. So ICU is required. So initial treatment, remember it, I for initial treatment, I for ICU. Okay, you have to take care of life-threatening conditions. You have to make sure the child is free from life-threatening conditions under ICU. Okay, that is initial treatment. Just give me one moment. Next, we have rehabilitation. So soon after ICU, the child will be shifted to general wards. Okay, so this is where rehabilitation will take place. Okay, the main focus here is child's nutritional rehabilitation. Okay, to make sure the child is catching up with the peers. Okay, all the micro deficiencies, macro and micro deficiencies are corrected here in rehabilitation, because now the child is safe. Now we know the child will survive. Once we have ensured survival for the child, then our task is to correct all deficiencies as possible, as soon as possible. Okay, that is rehabilitation. Intensively, we will feed the child. There is a specific timing. Mothers will lose their sleep here. Okay, because every 3 hours, it could be day or night, every 3 hours or 4 hours, whatever the physician has recommended, okay, the child has to be fed for the entire 24 to 72 hours. Intensive feeding has to be done. The mother may have to wake up every 3 hours, even at night, feed the child, give the specific dosage of feed to the child, go back to sleep. Okay, so that is rehabilitation. So intensive feeding is given here. Recovery, our main focus of recovery here is to gain the weight. Okay, whatever weight the child has lost, we have to gain it back. Also, emotional, physical, and mental stimulation of the child is also done here. Okay, and mother is trained well. Healthcare staff will train the mother well in how to make preparations, okay, how to feed the child, at what intervals, what signs and symptoms the mother has to look forward for, cues of hunger, okay. These all training will be given to the mother. Then we have follow-up. Follow-up is done once the child is discharged, okay. Once the child is discharged, the story will not end there with discharge. Weekly once, or whenever the physician or pediatrician has told the parents to bring the child back, the parents have to get the child back and see how the vitals of the child, see the recovery of the child. Okay. Parents may have a lot of questions here, questions regarding their own care. Okay, and see how the child is catching up here. After discharge, it's a task of the family, okay, to make sure the child continues in physical, mental, and emotional development. That is the family's task. Okay, then healthcare systems will just aid the family with some nutritional supplements. Okay, some rations that is provided by the maternal and child health services. Okay, ICDS, integrated child health program. Okay, they will provide some nutritional supplements through Anganwadis, through primary health centers, sub centers, community health centers. Okay, a lot of nutritional supplements, nutritional aids are given to the family. That all comes under follow-up care. Is it clear to all, the treatment and management? The basics of treatment and management. What is the concept of the managing a child here? So this is a treatment strategy: initial, rehabilitation, and follow-up. The same table is given in the textbook as well. You can refer that. This is for clinicians, clinical practitioners, pediatricians here. It is more useful for you. Next, coming to the principles of management. So when a child is dehydrated, okay, ORS is the first solution. 70 to 100 ml of ORS per, based on the weight of the child. Okay, whatever is the kg weight of the child, for per kg, 70 to 100 ml of ORS should be given throughout the day. Okay, you can make it at home as well. Dissolve 20 gram of glucose in 1 liter of water with a pinch of salt. Okay, you can make an ORS at home. You can heat 1 liter of water, boil it, let it cool down. Okay, add one entire fistful of sugar into it, mix it, add one pinch of salt into it, mix it. The water is ready, 1 liter of water is ready. And this 1 liter of water has to be given to the child throughout the day. Make sure within that 24 hours, the child completes this 1 liter of water. That's how you can make homemade ORS. And all the kids who have severe dehydration in hospitals, IV therapy, okay, IV fluid will be put on. Then when it comes to infection, antibiotics is given. Antihelminthics is also given if the child has any parasitic infections like Giardiasis, Ascariasis, tapeworm, hookworm infestations. Okay, antihelminthics will be given. If it is bacterial infection, antibiotics, viral infection, antivirals will be given based on the diagnosis. Okay, based on the laboratory reports, infections are treated. Hypoglycemia, give milk to the child, glucose in water with a little bit of lime, okay, lemon juice, okay, that is sufficient. Glucose can be given intravenously if the child is uh, in a comatose stage, okay, if the child has fainted, okay, through intravenous fluids, glucose can be still administered. Hypothermia, that is the body temperature has fallen down, way down beyond normal, okay. And usually marasmic children who have marasmus, muscle wasting, severe wasting, they have a high risk of hypothermia, okay. So the child has to be covered well with blanket. Blood transfusion, in some cases, blood transfusion is required. And it's ideal if mother is able to sleep with the child, mother and the child can share the same bed. It's ideal. Then we have congestive heart failure, either due to severe anemia or heart has undergone atrophy. We have seen that, okay? The size of the heart has reduced, so cardiac output is reduced. So these things can lead to congestive heart failures. So immediately code blue, diuretics, digitalis. Digitalis is the medications that will restart the heart, okay? Like epinephrine, okay? Epinephrine injections and all, they can just quickly restart the heart, okay? So that is digitalis treatment. Coming to formula diets, very important, okay? So when the child is in the rehabilitation mode, okay, when the child is moved to general wards, we are focusing on an intensive nutritional feeding. Okay, everything about the general ward care for the child is feed. What kind of feeding the child is getting. Okay, so here the formula diets are very important. We have two formula diets, F75 and F100. Formula 75, formula 100. The difference is formula 75 can give 75 kilocalories. Every ml or every 100 ml of formula 75 can give 75 kilocalories. Okay. Formula 100 will give 100 kilocalories. Okay. That is why they got this name F75 and F100. Okay. So you start with F75 and then you later move on to F100. That is the strategy here. Okay. So for severely malnourished children, these two formulas are used. F75 is used in initial phase when the child is in ICU. F75 is used, okay, when the child is recovering from or being treated for life-threatening conditions. F75 is the formula that we use. But when the child has recovered from life-threatening conditions, the child is safe. Okay. In the rehabilitative phase, that's when we use F100. Okay. Until and unless the appetite of the child has returned back to normal, these formula diets has to be given. And usually they are made by some basic mix, okay, like dried milk, sugar, milk powder, okay, milk powder, sugar, a cereal flour, vegetable oil is there, mineral and vitamin mix, water, 100,000 ml of water is used to make these formulas. So when the child is admitted to the hospital, okay, how do you feed the child? Feeding on admission. Do not overload the child's intestine and stomach with too much of feed. Okay. You think if you give a lot of feed to the child can develop better and quickly. No, it will overload the intestine, liver, and kidneys. Slowly, you have to establish a good feed. Slowly, you have to establish a good feed. Okay. Frequently, in small amount, when you give this feeding to the child, they can develop better. They can keep it in their stomach. Their systems will not be overloaded with digestive stress. Okay. And children who cannot eat, okay, who do not want to eat, for example, kids who have kwashiorkor, they don't have the appetite. They are not hungry. They will not eat. They will resist. Okay. In such cases, NG tube feeding is used. Nasogastric tube feeding. Okay. That is used. And children who can eat, like marasmic kids, okay, who do not have issues with eating, every 2, 3 or 4 hours, day and night, as I mentioned, okay, the intervals, is it 2 hour, 3 hour, or 4 hour? The intervals are decided by the doctors, okay, and every in that correct interval, the mother has to wake up. She as a primary caretaker, she has to make sure the child has completed the feed. Feeding after improved appetite, when the child's appetite has improved, the child is getting hungry, okay, in the initial phase or rehabilitative phase. Again, here overload is not done, okay. When the child's hunger has improved, you will switch to F100 feed, okay, immediately transfer to F100 from F75 to F100. And usually within 1 week, this change can come in. And gradually the transition has to be done to avoid the risk of heart failure. Coming to deficiency, the main deficiency you have to take care of is vitamin A. If the child is less than 6 months of age, just 50,000 international unit of vitamin A dosage is given on day 1. If the child is between 6 months to 1 year of age, 1 lakh international unit of vitamin A is given. If the child is slightly older, more than 1 year of age, 2 lakh international unit of vitamin A is given on the first day of admission to hospital. Day 2 also, the same dosage has to be maintained. And at least 2 weeks later, after 2 weeks, the same dose what you have given based on the age of the child, you have to maintain the same dose. In anemia as well, if severe anemia is there, blood transfusion is required. Otherwise, nutritional supplements can be given. And in initial phase, iron should not be given, but in rehabilitative phase, iron supplements can be given. The nutritional rehabilitation, it is the same thing, initial treatment, rehabilitation, and follow up what we have discussed, that itself is nutritional rehabilitation. In a figure they have mentioned, figure 8E, okay, on page number 169. You can refer that. It's the same concept what we have discussed so far. If a child is under 2 years of age, every 4 hours, for every 4 hours, F100 diet has to be given day and night. And slowly you increase the amount of the diet. The first time when you give F100 diet, it's just 60 ml. In the second feed, you will give 70 ml. In the third feed, you will give 80 ml. So slowly, just increasing 10 ml, you are increasing the quantity of the feed. Okay. In one go, you will not give a big dose of feed. Slowly, you have to increase the dosages of feed. In follow-up, as soon as the child is discharged, again, kwashiorkor and marasmus is seen in families who usually come under BPL category, below poverty line category. They may not have the resources to come on a daily basis, on a regular basis to the hospital, get the treatment done, lose their daily wage or labor wage, okay, for just to come to the hospital. Okay, they cannot afford it. Okay, so best way is to guide them to use other services like ICDS plans, Anganwadi system, nutritional supplements, okay, PHC, sub center. You have to plan a follow up for them so that they are not risking their professional loss, financial loss, just to get the treatment done for the children. Then diet during convalescence. Convalescence means the discharge has been done, the child is recovering, follow up is still going on. So that period, okay, from the health has been stabilized, okay, the health has been stabilized, but it is not there yet. It is not, the child is not completely healthy yet. Okay, that time frame, health has been stabilized and the child is on the path towards an ideal healthy state. Okay, so that time period is called convalescence. Okay, so during convalescence period, what the family has to focus, okay, increase the quantity of the food. Okay, like idlis, rice, chapati. If the child was having just one idli, start giving the child 1.5 idli or 2 idli. Quantity has to be improved. Okay, increase the number of meals, short and frequent meals, so that can satisfy the calorie requirement. Add 1 teaspoon of oil in the food. If the child cannot deal with high quantity of food, okay, you can make the food calorie dense by just adding 1 to 2 teaspoon of uh, saturated fat, ghee or butter or oil to the food. Sugar and banana consumption has to be increased. Mixture of cereal and pulse, okay, in form of 5:1. 4 part of cereal, 1 part of pulse. Okay, that kind of a combination can be given. If the family member can afford milk, egg, okay, skimmed milk, you can include that. Encourage the family to eat more local, inexpensive, and easily digestible food for not just for the child but for the entire family. Then we have the root diet, okay, that is ready to use therapeutic food. So it took almost years, 5 to 9 years, for National Institute of Nutrition to make this ideal diet mix. Okay, this is the diet mix. Nothing you have to do here. This roof diet is given free of cost. It is distributed through Anganwadis and PHCs to malnourished children and the family. Okay, you just have to open it and directly give it to the child. The child will eat it as it is. Okay, you have to knead it a little bit. Okay, just to make sure you mix it well. Just open the package and let the child enjoy it. That's it. That is the roof diet. You don't have to cook it. You don't require a fridge to store it. Okay, it can last a pretty long time. It is FSSAI approved as well. Okay, ingredients are very simple, like roasted peanut, sugar, milk powder, vegetable fat, vitamins, mineral complex. Okay, easy ingredients, okay, and it will just one package of it can give 500 kilocalories. Okay, so it can really improve malnourishment. It's a calorie dense food. And also peanut is the main ingredient in this sort of diet. And peanut allergy is not something that is very common in countries like India. In Western countries, it is very common, but in countries like India, peanut allergies are not that common. So it is a really good way to ensure that the child can catch up in the growth phase, meet their peers, healthy peers at the right time and as soon as possible. So prevention of malnourishment, health promotion, make sure pregnant women and lactating women themselves are educated, healthy, so that the rate of severe acute malnutrition falls. Okay, if the mother is healthy, the child will have a healthy life. Specific protections like child's diet should be energy-rich milk, egg, fresh fruits, vegetables should be present. Universal immunization program has to be followed. Polio drops, okay, MMR vaccine, all vaccinations has to be followed. Food fortification, use fortified food, okay, oil, salt, atta, okay, everything that is milk that is fortified, as much as possible, use fortified food. Early diagnosis and treatment is better. Early surveillance. Look out for the signs and symptoms of malnourishment, infections, diarrhea, severe diarrhea, recurrent diarrhea. Deworming children, that is giving the children anti-helminthics, because hookworm infestation, tapeworm infestation is a very common in young children. Okay. Then ICDS program, Integrated Child Development Program. So they have funded a lot of nutritional programs and schemes in India to prevent malnourishment in children and also in mothers. Immunization, treatment for minor illnesses, growth monitoring, health education, they all come under ICDS. Then nutritional education, through Anganwadi teaching young school girls, okay, mothers who come for antenatal checkups, okay, teaching them, targeting them as the market for nutritional education. It will improve the community as a whole. So these are the prevention strategies. So that support severe